Good afternoon. We are going to begin with the debate 3 and with a very controversial issue. It's resection of oligometastatic liver disease in pancreatic cancer patients. Yes or no? It's a pleasure for me to present two presenters. And the first one is the professor Chris Wolfab. He is the chief of the Division of Hepatobiliary and Pancreatic Surgery at New York University, Langone, and professor of surgery at New York University Grossman School of Medicine. Thank you, and the floor is yours.
Thank you very much. Well, thank you for that kind introduction, and thank you for the privilege of the floor. So, my goal today is going to be to convince you that resection of oligometastatic pancreatic cancer is reasonable and actually makes sense and will actually improve survival. So I have nothing to disclose. So like I said, I'm going to convince you that resection of oligometastatic disease, liver only, should be performed in selected patients. I'm going to base my argument on a comparison to colorectal liver metastases, showing some of the similarities and the differences. I'm going to have a discussion of tumor biology in the argument. I'm going to talk about improved systemic therapy. And then finally, I'm going to discuss some of the outcome data, which admittedly is relatively sparse. So let's start with colorectal liver metastases. Everybody in this room knows that this is now standard of care. That it is, many of us have built careers on resecting colorectal liver metastases. And how are the outcomes? Well, the outcomes are excellent. And I apologize here. These are not some of the key studies, but there's many others that I could have included. But look at the 5-year overall survival rates in resected metastatic colorectal disease. Very reasonable survival rates. If you look at median survivals, we not only cure certain people or extend their survival beyond 5 years, but at least we extend their average time. So I think no one would argue that resecting metastatic colorectal liver metastases is actually standard of care and something that should be done. Now, I'd like to say that history repeats itself. Okay, and I think that there's many, many examples. The recent epidemic that we had was not the first time. I've heard many times unprecedented, but it's really not. History repeats itself. So I'm sure long before IHPBA and AHPBA ever existed, there was somebody like me standing up at SSAT and trying to convince everybody back in the 1980s, 40 years ago, that we should be resecting colorectal liver metastases in select patients. This was a summary at the time, basically, it had nothing to do with resecting liver metastases, but gave a status of the state of affairs in the treatment of colorectal cancer. And it says the role of surgery in the treatment of disseminated colorectal cancer, including liver, is limited and seldom offers a prospect of a cure. Now think of the data that I just said. So turn the clock ahead 40 years. So again, keep in mind, history repeats itself. Now, why is this sort of standard of care in colorectal disease? And it has to do, in my mind, with several things. First of all, colorectal has a favorable tumor biology. Favorable is a relative word, right? If you have metastatic disease in your liver, how favorable can that be? But it is relatively favorable. And I'll explain what I mean by tumor biology. We know that there's responsiveness to systemic therapy, both chemotherapy and in some cases biological therapy. We have agreed upon selection criteria for who we would resect, who we wouldn't resect. There's some gray zone, obviously, but basically it boils around once good biology is selected is having enough future liver remnant. It's not number of lesions, but these are relatively agreed upon, tried and true criteria. And we all know that hepatectomy can now be performed safely by this crowd. We're presenting to a very specialized group. I think nobody would argue here that we can do major hepatectomy safely. Whether we're doing a hepatectomy for metastatic liver, colorectal liver disease or for pancreatic disease, it's the same technical resection, and we can do it safely. And then finally, as I showed you, colorectal is supported by the outcomes. So again, realizing that hepatectomy is something that we can argue is the same in both of these disease processes. I'd like to go through the tumor biology, responsiveness to therapy, and selection criteria in the context of where we are in pancreatic cancer and convince you that it is reasonable at this point to move ahead in resecting select patients. So let's talk about tumor biology. Well, what is tumor biology? Tumor biology is a general term that we use as clinicians to describe multiple things. It's like one of those things, it's hard to define tumor biology, good or bad, but we know it when we see it. And on a molecular level, it has to do with mutational profile, accumulation of mutations, propensity for systemic spread, you name it. There's multiple markers for bad biology and good biology, but we know it when we see it clinically. We also know this, that no two pancreatic cancers and no two colorectal cancers behave the same. So in general, yes, colorectal cancer is a better biology than pancreatic cancer, but we see at some ends of the spectrum well-behaved pancreatic cancers, and we see very aggressive colorectal cancer. But even in a relatively aggressive colorectal cancer that meets selection criteria, we still would not argue to not resect that patient. And so there is overlap in the disease biology. And it's all about numbers. If you take 100 patients with metastatic pancreas and 100 patients with metastatic colorectal, maybe only 10 or less of the pancreatic cancer patients may have good biology, whereas 50 have good biology. But nonetheless, when they have good biology regardless of the source of the disease. Now, I'm going to ask a question, and I think everybody knows the answer. What is our most common pattern of failure after a potentially curative resection for any GI adenocarcinoma? It's distant metastases, and that's also the #1 reason of death, distant metastases. Now, where do distant metastases come from? They come from micrometastatic disease. So as all of us here in the business of local control know, is that we always are operating in the spectrum of micrometastatic disease. If we remove all gross disease, and we base our living on this, the outcome depends on the control or the eradication, or in some cases, very rarely, the absence of micrometastatic disease. And so micrometastatic disease exists as a spectrum. We indirectly measure, we know it's there, we describe it as tumor biology, but let's take a stage 1, 2 patient, say for example, and we draw an arbitrary line, and this line is arbitrary, as I'll tell you, metastatic or micrometastatic, meaning subclinical disease. And let's just say a stage 1, stage 2, early stage, relatively small pancreatic cancer, we still are operating in the context of micrometastatic disease because we know that the pattern of recurrence is systemic. Now, let's take a patient who maybe has a mildly elevated CA19-9. We know, in general, although we can't see it, there's probably more micrometastatic disease, and the data would suggest that the failure rate is higher. But nonetheless, you wouldn't tell that early-stage patient we're not going to operate. Of course, we can have the discussion on neoadjuvant or not neoadjuvant, right? Let's take a patient now who had, say, an elevated CA19-9 of 1,500. Well, whether or not they respond to neoadjuvant, we know that their baseline micrometastatic disease, what we can't see, is high, okay? But, I mean, after neoadjuvant, after a response, no progression, I mean, I think most of us, we're getting a little bit in the gray zone here, would operate on that patient. Now, what if tomorrow we developed a test that was so much better at picking up metastatic disease than what we have now, and that same patient, we would find a little DIT dot in the liver? Now we can see some of this micrometastatic disease. Would we operate on that patient or would we not? It's a little bit of an arbitrary line. But I would say, why not cross the line? And even in metastatic disease, again, if you get back to what we do as a surgeon in local control, if we can clear the patient of all gross disease, what do we leave them with? The same thing we leave them with when they have stage 1, stage 2, micrometastatic disease. So that leads us to responsiveness of systemic therapy. In pancreatic cancer, in all adenocarcinomas, we either depend on the absence of micrometastatic spread or the control of micrometastatic spread through chemotherapy, regardless of whether it's stage 4 or stage 2. So this brings us to chemotherapy. And we won't get into a discussion of the advances in chemotherapy in colorectal, and I can tell you that the advances have not been as much in pancreatic cancer, but clearly we've moved the needle a bit. When I first started as faculty, the overall survival was 4% for pancreatic cancer. It's now 10%. really there's no development of early detection. A lot of this is driven by multi-agent therapies, and we know that in level 1 evidence that the control of progression is better with these multi-agent therapies. So we still are not nowhere we need to be, but I do think we have much better control of micrometastatic disease. This is work of Jin He, who's sitting right here in the front. And this is a population of patients, pancreatic cancer, were treated with neoadjuvant. It was a mixed bag, multi-agent therapy in the most part. And, you know, we had the whole spectrum of responses. But it's important to note that about 10% of patients had a path complete response. Obviously, a selected group, right? A selected group, not most of them didn't, but this select group had a path complete response because of systemic control, because of chemotherapy, and they had systemic control, and that equated to micrometastatic control. You can see the survivals in that group are far and away better than not having micrometastatic control. All about selection. Now this brings us to selection. What are we selecting for when we're selecting? And we do this all the time, but I don't think that we actually think really what we're selecting for. We're actually selecting for the ability to control or eradicate micrometastatic disease, or in those rare patients, the absence of micrometastatic disease, and good biology, which the two are sort of related. Now, this is where it starts to deviate a lot from colorectal, right? In colorectal, you know, we know that at baseline the biology is better. We also have better developed tools for selection of biology. And this is where, again, we are developing it, but I think we have enough understanding. Right now, most patients, particularly elevated CA19-9, even sometimes normal CA19-9, receive neoadjuvant therapy, or in the case of stage 4, induction chemotherapy. And I'm personally a believer in that, early control of micrometastatic disease. How they behave on neoadjuvant tells us if we are controlling micrometastatic disease. If they blossom new liver lesions, we don't have control of micrometastatic disease. That patient's not selected for. Imaging response. Now, we're going to cut out what we see, assuming they have oligometastatic disease in a primary phase. But if you see a response of the primary, well, that's great. We don't care that it shrunk. You know, we're still taking it out. But indirectly, it infers if the primary is responding, the micrometastatic disease is responding. And as a surrogate for systemic disease, CA19-9 in those patients who express Lewis antigen, it's an excellent marker for micrometastatic disease. And so that's what we use for selection. Now here's an example, and this is also work from Jin He and from the time I was with the group. And this is an example, and I don't mean it in a bad way. I'm not criticizing Dr. He here. This is an example of bad selection versus good selection. So these two bars here are simply patients who, like, well, there's a liver lesion, we found it at operation, but it's a single liver lesion, maybe we'll go ahead. Or, you know, maybe the patient, we knew the lesion, we went ahead in the absence of preoperative chemotherapy, no selection process, and you can see, I think it's blue, and that's, you see the survival care. Now compare that to patients who had selection with induction chemotherapy, known oligometastatic disease, selection process. We selected for good biology. Yeah, it's not remarkable survivals, but nonetheless, it demonstrates that we can select with the tools that we have. CA19-9, size of the tumor, and basically lack of progression. So let me close now with the outcomes, and I agree that it's relatively sparse level 3 data. So, you know, if we were having this discussion maybe 8 years ago, you know, honestly, I mean, I'm pretty data-driven. And you look at the studies, you know, 2007 up to 2012, we were using single-agent, less aggressive chemotherapy. In some cases here, chemotherapy was not used in the majority of the patients. And of course, you know, no better than palliation. And in fact, if you open them up and do an operation that's non-therapeutic, it's worse than palliation. So I understand that. But if you start to move into contemporary period with FOLFIRINOX or gem-nab-paclitaxel, multi-agent therapy, those that respond and are selected for, look at those median survivals in months. I mean, that's reasonable. That's within what we see in stage 1, stage 2. Now, I want to point out this study from Thilo Hackert in contemporary area, and obviously, you know, the Heidelberg group, skilled surgeons, they understand tumor biology, you know, and they selected patients based on tumor biology. What's the difference with this study? Single agent gemcitabine. To me, although it's not a direct comparison, this to me, supports the hypothesis that we have better control with micrometastatic disease with the multi-agent therapy. So time to think about it. I think this is probably the best well-done study. It's a retrospective study. It's out of Massimo Falcone's group. Retrospective analysis, 127 liver-only metastases. They were treated with a combination of things. The majority had combination chemotherapy. Some had single-agent gem, but they selected. 44% of the patients had a significant clinical response. Out of those 56, I don't have time to get into the details, they further selected 11 of the responders who went to resection. And look at the dramatic difference in those patients. Compare the no resection to surgical selection. You say, well, this is a retrospective study. It's selection bias. That's my point. We can select for patients who will potentially benefit from surgical resection. So in conclusion, I would like to submit to you that resection of oligometastatic liver-only disease should be performed in select patients. And these conclusions are based on a comparison to colorectal and where we are in the time spectrum of development of chemotherapy and selection tools. And selection tools are very important, a whole other topic that is near and dear to me. I would submit that a subset of pancreatic cancer patients have favorable tumor biology, and that current multi-agent therapy is increasingly effective, and we're making incremental increases in the effectiveness. Preliminary, albeit level 3 evidence, suggests a survival benefit for resection. Now, we always end every talk in this, and 90% of the time we don't mean it, but is it really time for a prospective trial? And I think it is. The only thing that I would tell you at this point is, do we have equipoise? So, and I'm going to ask a question. I want to show of hands, and that's how I'm going to conclude. A 54-year-old woman comes into your clinic. She has localized pancreas cancer. She's going to need a Whipple operation, no vessel involvement. She's ECOG 0. She's there with her husband and 2 daughters. And she's been treated for 4 months. She had an initial CA19-9 of 1,500. She's been treated 4 months, FOLFIRINOX. And she has a single lesion in segment 4B. Her CA19-9 went from 1,500 to 200, didn't normalize. A show of hands, who would not offer that patient surgery? Who would not offer that patient surgery? Okay. Just interesting to know. All right. Thank you very much.
Thank you, Chris. Yeah, here. Yes. We are going to discuss at the end of the 2 because you say yes, and now we are going to no. Professor Nicholas O'Rourke is not here, is going to be virtual. Please, he's the head of HPV surgery at Royal Brisbane Hospital and professor of the University of Queensland, Australia.
Good afternoon, everybody in New York City. Greetings from sunny Brisbane, Australia. I'm Nick O'Rourke, and I hope I was not chosen for this no debate because of my initials. I'd love to be there in person, but a series of international and local events have prevented me from getting there. But as I say, it would be much better to be debating Christoph in person. In principle, should we resect a few liver metastases? Can we think about it in highly selected cases? Maybe. Can we recommend it? No. Don't do this to Christoph, however. I'm sure he's put a very cogent argument as to why occasionally we can do this. Looking at the guidelines, and there are many guidelines out there, these are recent ones from NCCN, and the answer is no. Interestingly, they have a 5% rule when they do all their guidelines, which eliminate the uncommon clinical scenarios. The unicorns, the outriders, the occasional survivors from resection. Today's debate, I will talk about synchronous metastases first, and the treatment of them, followed by metachronous, and you're very lucky because I will include a little survey on local surgeons' attitudes. Look at this rock star, my predecessor. Christoph wrote a nice little paper in 2007, a systematic review, and the answer came back as no, was not justified. Now there is creeping enthusiasm in the literature. It does look tempting occasionally to a surgeon. What's changed? Are knives sharper? Christoph certainly looks more thoughtful. Surgery may be a bit safer perhaps, but still we have reports of mortality of up to 8% and serious morbidity, as all pancreas surgeons know. MIS has certainly boomed in the last 15 years. Similar pathology, however, hopefully similar outcomes. So that's not really changed our view. I think as surgeons we do hate feeling powerless. The worst feeling you can do is go out to talk to a family and say you can't do anything for someone you may have done a big laparotomy on. That's very unpleasant for all of us. Much better to be a knight in shining armour, to say, I've done something. What's this knight got over the last 15 years? What's improved for him? It's chemotherapy. Better chemo with this landmark trial with FOLFIRINOX versus gemcitabine back in the New England Journal over 10 years ago has led to an explosion in the use of this combination therapy with some very impressive results. Even as neoadjuvant, which is widespread now, occasionally will get complete pathological responses. And this paper from Alan Sung said it was up to over 3%. So there is this enthusiasm for synchronous liver mets, which I think is encouraged by the responders to chemotherapy. My little survey, and I want you to think about these questions moving forward, was I asked the local ANZ, which is Australia, New Zealand, or Aotearoa, as we're meant to call it now, is there any role for surgery in PDAC liver mets? Does improved chemo make surgery more likely? Would you do a Whipple procedure plus 2 lesions in the left lateral synchronously? Would you do a distal with 2 lesions in left lateral synchronously? Would you resect a PDAC met 1 year after Whipple? Think about these because they'll pop up and I'll give you the answers at the end, and I want you to think about how your response would be and whether I can change your mind at all. First one, I was very surprised by this response. 2/3 of our local surgeons says yes, there was a role. A broad question, but there was a role. I'm going to look at some recent studies. Just pick a few out, a few big ones from Germany, China, and multi-centre studies. A nice one from Berlin, almost historic though, looking at 20 years up to 2015. 76 patients underwent hepatectomy at the same time as liver resection, as pancreas resection. And look at the survivors. There were a couple of long-term survivors. In this series, all but 2 mets were discovered at laparotomy, not on preoperative staging, just at laparotomy. And down the road from Berlin, in Heidelberg, one of my surgical heroes and friend is Markus Buchler. He has spoken recently where he says if you're doing a laparotomy and you're doing a Whipple and there's a little metastasis and it's smiling at you, take it out. And that's certainly Marcus's attitude. Is it reasonable? I'm sure occasionally it is. This big series from Heidelberg was published recently. So these are patients who've had 85 patients with liver metastases resected with the primary, still a median survival of 12 months, but there were a couple of outriders living 5 years. A reasonable mortality, but look at that 45% morbidity. These patients do spend a lot of time in hospital often. Up the road in Dusseldorf, another nice series looking at synchronous resection. 180 patients with primary, looking at PDAC, with 35 of these having resection at the time of the primary. There was variable chemotherapy because of the time course. The staging imaging was unstated. And as expected, the resected primary does better than the resected primary with the liver mets. And the resection does better when there's just palliation. But still, 90% of these resected liver met patients were dead within 2 years, and nearly always with more liver disease. So we're just picking the winners. There's still occult disease in the liver which will recur. And look at these figures. They did have a high mortality and a long median stay. And when we see a median stay of over 3 weeks, all surgeons know that that represents quite a few people who are spending a long time in hospital. Shenyang, some of you may not have heard of Shenyang. It's a city in China of only 17 million people, so almost twice as big as New York. I'm sure there's many centres there, but this centre published their results recently, demonstrating that over 50 patients with a radical resection of primary pancreas with the liver resection, people do a bit better. But still, there's only a 20% 1-year survival in these synchronous metastases treated radically. So these little papers demonstrate that synchronous liver mets can be resected with a reasonable mortality, but really, would they be better off sometimes with no surgery, spending time with their family, perhaps having other treatments? Is it that morbid Whipple they've undergone with the liver resection, could that be futile? And we all want to avoid futility. Again, I'm giving you some answers on our little local survey of over 30 surgeons, all HPB specialists, all doing pancreas surgery. Do you think that the more successful chemotherapy makes oligometastatic surgery more likely? And not surprisingly, 4 out of 5 say yes. Comments in this survey were that depends on accurate staging, and I think this is so important if you are considering resection of what may be surface metastases, that you know there's not more there, and you know by the best techniques possible. I think it's expensive, but the best image staging available today is an FDG PET, an MRI with Primavist or Eovist as you called in the States, and possibly laparoscopic staging. We did a little study on FDG PET in Brisbane a few years ago and found that it did change our management in 16% of patients, picking up occult disease, which wasn't detectable on standard imaging. We know that with Eovist MRI, we will pick up more liver disease, much more sensitive than a standard multi-phase CT, more sensitive than a standard MRI. And this was proven nicely by my friends in Toronto, with, again, changing management in 10 to 15%. An interesting snippet from their paper was they pointed out a 55-year-old female where a solitary met was seen, biopsied, and then surgery was avoided. That would be, I guess, most of our practice around the world, rather than saying that's one liver metastasis, let's excise. Staging laparoscopy is perhaps not as popular as it once was because imaging is so much better. It's still possible, however, to see surface liver metastases. And more, as we know, major pancreas resection is being done laparoscopically, so you have more decision making to make on the basis of what you see at laparoscopy. When I asked our local surgeons, would you perform a distal pancreatectomy and a simple liver resection for a solitary segment 3 liver metastases, I was surprised that 1/3 said yes, they would. A Whipple, people are less enthusiastic, and only 1/4 said they would. I presume they're the knights in shining armour, the young Turks and young Turkettes in our community who are hungry for work. With synchronous liver metastases, there are occasional outriding unicorns. However, as we've seen, most do badly. You must stage patients accurately, avoid futility, and it's becoming pretty obvious, I think, that chemotherapy must be given first. Looking briefly at metachronous liver metastases, a quick history, because there's been quite a few publications on resections of non-colorectal, non-neuroendocrine liver metastases over the years. And when you're looking at this, don't forget that a liver resection can be difficult after Whipple. You can't do a Pringle, and the liver is potentially contaminated from the HJ. Give my respects to Bernie Langer, who, as you may know, died recently. They published in 2000 37 liver resections, and only 2 of these were for PDAC metastases. In Basingstoke and Brisbane, there was a combined series and only, again, 2% of the whole group were for pancreas primary. So it's rarely done historically. When I asked Merv Rees, the lead author of this study, of his current series, he's done 4,000 liver resections and none himself for pancreas metastases. A French multi-centre review showed only 3% of all liver resections for non-colorectal disease were done for pancreas metastases. More contemporarily, there's a few papers coming out. This is a nice little one from Tokyo, and they showed that if they had a decision-making process that if patients had stable disease for 3 months with 3 or less metastases, they were offered surgery, big operations, clever surgeons, no morbidity but long operating time, and there wasn't an outlier. There was a survivor, but really not great results. Most people still died of disease within 2 years. A more recent study, multi-centre, German, Austrian, USA, nice paper, but still small numbers really from 7 centres, only 3%. So highly selected numbers. We are helping some of these people, all right? They are living longer, but when they get recurrence, it's all coming back in the liver. We're just not detecting those micrometastases which then recur. So we're not really curing people. We are giving them a bit of an edge, but we're not curing them. Their conclusions were that liver resection for metachronous PDAC is safe, safe sort of, careful patient selection is important, and everybody should receive neoadjuvant chemotherapy before liver resection. When I asked our local surgeons, would they do a metachronous resection? Again, slightly surprisingly, 1/3 said yes. So there is some local enthusiasm for it. Just to temper that, I'll give you some recent salutary tales from Brisbane, which is today, as I speak, flooding again. So this patient was one of ours, had a 1-year recurrence, looked solitary on CT and MRI, wedged out. 12 weeks later, multiple lesions. This patient had a metachronous 2 years after a Whipple. Metachronous lesion. Looks tempting. That was all that could be seen on staging. Was cut out. And then 3 days later, he was back to the operating room for sepsis. It was actually too sick to have a CT to demonstrate the sepsis, and he's got still has ongoing drainage from this contaminated collection. So it's not always unmorbid. You've seen this image before as I've gone through. This patient was only done recently. A solitary liver met was seen, biopsied, 6 months of TNT, both resected synchronously, and there was a complete pathologic response in the met. So was it worthwhile? I can't say. So in conclusion, ladies and gentlemen, Mr. Chairman and Christoph, synchronous liver resection with PDAC primary, maybe rarely in highly selected patients. Can we recommend it? Sadly, no. Metachronous liver met resection from PDAC, it may be rarely in highly selected patients. Remember, there is increased morbidity, especially after Whipple. Can we recommend it? No. The future is bright for surgery in PDAC, however. We will all hopefully become knights and knightettes and operate on more and more people over time, because multimodal therapy will actually increase that pool of patients who may be possible. Select your patients well, operate safely, and I'm looking forward to arguing further. All the very best from Australia.
Thank you very much for the excellent presentation. Now we are going to answer the question. Do you have any question for the
I
floor?
think they're also trying to get Nick on the phone too from Brisbane. Do we have a microphone?
Thank you so much for very good talk. My name is Vyacheslav Egorov. I'm from Russia. And as for me, you was much more convincing than your opposite part. But my question is, what do you consider oligo metastasis?
So that's a great question. So for those who didn't hear the question, it's what do we consider oligometastatic disease? You know, it's sort of an arbitrary thing. Again, if you go, going back and drawing on colorectal, and those of us who've been around long enough, I remember when the selection process, and I don't even remember it now, was like 3 lesions, less than whatever. I can't remember it, right? It sort of was an arbitrary thing. But as it migrate and has progressed, it's actually gotten to the point as can you clear them of all gross disease with a large enough liver remnant, right? And so I think that biology really dictates not the number of Mets or whatever. Now, the practical thing is if we really do a well-designed trial, that I think that, we have to determine that. Like, what are we going to call oligometastatic disease? And, I think if I came up and gave you a number, it would just be an arbitrary thing. For me, it's unilobar disease, something that can be cleared without necessarily, an extended hepatectomy on top of a Whipple operation. But, I don't think that that's going to be ready for prime time for trials. I think it's going to take a committee of people who do a lot of this work and decide what are we going to arbitrarily call or oligometastatic and run the trial based on that. And then based on what we learn, move it to where colorectal is. The other thing too, and this I think is going to address many things when Dr. O'Rourke and I sort of rebuttal, but one of the limitations that we have in pancreatic and actually all GI malignancies is that we fly blind, that we don't have really great markers to guide us and that measure biology. We need better measurements of tumor biology. And I think that liquid biopsy is the future. Like in the simplistic, most simple level, we have CEA and CEA-99, and they're pretty good surrogates for micrometastatic disease. But now with circulating cell-free DNA, circulating tumor cell, extracellular vesicles, do we have better, more sensitive tests? So in other words, is there a patient who has, and you pick either colorectal or pancreas, who has 5 or 6 liver lesions, in the right and the middle segment 4, but they have a low biological marker. And so, okay, so it's a technical exercise. We know we can do an extended hepatectomy, but their biological marker tells us they will do well, as opposed to one little single liver lesion in the right lobe with a high, marker for bad biology that's don't touch that. And actually, again, it's all about the spectrum, right? When I talked to Dr. O'Rourke, a lot of the things that he said are absolutely true, and I agree with. But actually, the early recurrences, the early progression, we see that right now in localized pancreas cancer. So should we just stop operating on everyone? But I think the answer is no, and I think it's all about selection and developing biomarkers. So we're in the infancy of where we need to be.
Thank you. There is another.
Yeah. Isabella Frigerio, Peschiera del Garda, Italy. I agree with your conclusion, so I am in favor of a resection of oligometastatic pancreatic cancer. I don't fully agree with the background. Not with the cancer-directed surgery for pancreatic cancer. I have a question. Would you leave some time free from chemotherapy before performing surgery when you tested these patients for a response to chemotherapy? Because I think that it's a process that is time-sensible. The most you wait, the highest is the probability that you can select good patients for surgery.
Yeah. So let me tell you, that's actually a great question. And I'll tell you what I do, but I'll tell you what I agree with. It makes complete sense that we test somebody off of chemotherapy, that we give them a course of treatment. We say, well, that looks like a great response. They're a potential for surgery. And then let's see how they behave additional 4 months off of chemotherapy, right? Because that's basically what they're going to get after surgery, right? So that actually probably is the best selection process, but that's not my practice right now.
But if you look at the CA 19,
Yeah.
what is the limit? More than 50%? More than 19%? Do you think
Yeah.
something?
You know, the data out of Pittsburgh, I'm not sure if the Pittsburgh group's here, SUSI out of Medical College of Wisconsin, in localized pancreatic cancer in patients who localized disease, treated with neoadjuvant who have elevated CA19-9s, the true best outcomes are the ones that have normalization of their CA19-9. So that's what we would try to achieve. Nonetheless, even in localized pancreatic cancer, we don't achieve that. And then we make the decision, are we going to pull the trigger or not? I mean, statistically, those chances are less for cure or longer-term survival, but nonetheless, within that cohort, you know, we do have long-term survivors. It's just we need better selection tools. So I don't have a hard and fast number. I mean, it's, again, this is where, as a group, not just my opinioners, we have a lot of experienced people. I know there's a lot of people doing it. You know, is to sit down and say, what are the criteria, and come up with defined criteria, and then study it prospectively so that we can learn. Because right now, I mean, you know, putting everything, like you may say, well, we had only a 50% response, but it's a 50-year-old woman or 50-year-old man who's healthy. It's a little bit different than maybe a 60-year-old who's a little bit frail. But you know what? The 60-year-old who's a little bit frail, if they have a complete response, I might take them. So it's, you know, it's sort of like a little bit of artwork, right?
We have another.
Chris, that was outstanding. And you and I have talked about this before. You already mentioned what I was going to first ask about, which is liquid biopsy. But the idea that if we can just be somewhat optimistic about the future, none of us years ago would have ever imagined the successes we've seen with FOLFIRINOX.
Right.
And that's not going to be the last one.
Right,
Something else will
exactly.
be better.
Right.
And we'll be better at liquid biopsy.
Right.
And so this may look like that paper you referenced from colorectal metastases that now looks prehistoric,
Yeah.
that everyone thought it was a bad idea. So.
Yeah.
As much as we can say what we want about the limitations of today's data,
Yeah.
I think there's every reason for optimism about the future.
Yeah.
in there.
Yeah, thanks for that comment. I mean, it's, you know, Bill, you and I have been around long enough to see the progression in the chemotherapy for pancreas, and we've seen a lot of the changes in colorectal. I mean, we need to incrementally move the ball forward. Now, we got to do the right thing for our patients, and we need to be safe. But I think if we stay static in the present, we're never going to move that needle forward. And I think that, you know, again, of all of the things that I discussed, it's all about selection. We have pretty decent tools for selection, and I think in people that we think have good biology, we should go ahead and do it. Or at some point, you know, everybody talks about the morbidity of the operation, but in the hands of the people in this room, you know, the benefit of resection, and forget metastatic or localized, even in localized, there's morbidity and mortality associated with, but the benefit of resection outweighs the morbidity, right? So we need to select those metastatic patients in which the benefit outweighs the morbidity. You know, the morbidity's with us, and it's going to be with us probably. I mean, I can't foresee any cure to, you know, pancreatic fistulas except for total pancreatectomy, right? So it's just, these are the tools we have to work with. It's still an aggressive disease, and nonetheless, we actually save lives by operating on those patients, realizing, I'll be completely honest, it's maybe a little nihilistic, 80% of the people we operate on, we're going to fail. They're going to die. But I can show of hands again, who's going to stop operating on pancreas cancer here? You know, I think very few. So, you know, on that spectrum, we need to push the needle, but we need to, at the same time, develop better selection tools. I think that's the next incremental thing, and things are going to unfold simultaneously. You know, as Dr. O'Rourke pointed out, you know, hepatectomy in the setting of having an HJ is a bit more problematic than not. So, you know, that's something that needs to be studied. We need better tools. Somebody needs to be working on liquid biopsy or functional imaging that helps us. And at the same time, and it will happen, is that we will, you know, that's Nick calling in, I think. So, and over,
Hey.
Nick,
Yeah.
Chris Wolfgang.
Hello.
Hey.
Hello.
Hello. Hello. Can you hear me?
Yes, can you hear
Yes.
us?
Hi, everybody.
Hello.
Hi, Nick.
I'm greetings from Australia. Can you hear me?
Yes.
Yes,
Yes.
can you hear us?
all that I've heard is that Christoph agreed with everything I said, which is very reassuring.
So,
Hello all.
Claudius,
I think Christoph is handling the situation well. I have nothing much to add.
Nick,
Okay.
you gave an excellent talk. You almost had me convinced that I should change my answer to no, and then my head cleared at the end, and I'm back to yes again. But it was an excellent talk. You know, we actually are looking at the same data, and I agree with everything that you said, but I think the devil's in the detail. You know, you pointed out the unicorns, and you know, but those unicorns, I mean, not all of them do uniformly well, but those unicorns have the potential to do well. And you and I have both been around long enough that, you know, back when we were not even sure about adjuvant therapy and back when we had single agent chemotherapy, the unicorns were much less. We didn't see as many unicorns. You know, now it's a matter of numbers. We are now seeing more and more unicorns. And so, you know, in a busy pancreatic surgery practice, you know, every week we see that patient that in the past would have been a unicorn and maybe potentially will benefit. But I think I agree with what you said, and we're saying the same thing. But I do think that it's time to be aggressive in this subset of patients that have, for all best we can tell, relatively reasonable biology.
Yeah, I completely agree. It's just, I think, from the point of view of the debate, it's hard to give a blanket recommendation that we should be aggressive. But I think in highly selected patients, of course, we should do all we can. And the modern chemotherapy is selecting those patients, helping us select these patients, isn't it?
Yeah.
So that we can. 2 days ago, I resected a intraperitoneal solitary metastasis 4 years after a distal pancreatectomy for PDAC. So, which went technically well, but she's struggling a bit now, and I'm waiting for the phone call. That might be leaking. So
You just gave it away. I just won the debate now.
you did win by point of view of being there. So I do apologize for your IT service.
So one of the things that came up before I think before you were logged in and could hear us, is there's obviously the chemotherapy is going to progress and it'll get better, and that's
Mr.
one thing,
Chairman.
but biomarkers to predict biology.
Can I